I am happy to present my progress on my PhD thesis of treatment of acute ischemic stroke. I am Esra Zhubi. I'm a PhD student at the Department of Neurology at Semmelweis University. My vision is to ensure universal access to early stroke treatment, enabling patients to lead disability-free lives. And my mission is to advance stroke prevention and treatment through dedicated and innovative research. These are my two specific goals, which I aim to complete through the methodology of meta-analysis. My first project is investigating the predictive role of flare positivity on clinical outcomes after intravenous thrombolysis in known-onset strokes. In 2019, according to the Global Burden of Disease report, there were more than 12 million incident cases of stroke and more than 100 million prevalent cases of stroke. Intravenous thrombolysis is the key treatment for prevention of disability. However, it is associated with the risk of symptomatic intracranial hemorrhage and risk of all type of hemorrhagic transformation. MRI and flare, which is the abbreviation for fluid attenuated inversion recovery, can play a crucial role in predicting clinical outcomes after an IVT in stroke patients. So our aim is to evaluate whether flare positivity is associated with worse outcomes after thrombolysis in known-onset stroke. Our clinical question is flare positivity associated with worse clinical outcomes among known-onset stroke patients undergoing IVT thrombolysis within the standard time window? Our population is stroke patients who undergo IVT within the standard time window. We will be comparing the patients with flare positive and flare negative acute ischemic lesions. Our first main outcome will be a hemorrhagic transformation and less favorable 90-day functional outcome. Our hypothesis is that flare positivity is associated with worse clinical outcomes in stroke patients who undergo IVT within the standard time window. Here is our systematic search that we conducted in 3 databases. And here is our flowchart of selection, which ended up with almost 10,000 studies. And we selected 6 eligible studies to be involved in our meta-analysis. Our first outcome is hemorrhagic transformation. Hemorrhagic transformation was defined as the presence of hemorrhagic transformation in the imaging 24 hours after the IVT, with or without clinical manifestations of it. So here we have included 4 studies, and the odds of hemorrhagic transfer, we can see from the samples in both groups that there were, we can see that there were 186 patients with flare-positive lesions and 618 with flare-negative lesions, and the odds of having a hemorrhagic transformation in flare-positive lesion patients was 3 times higher. Our second outcome is less favorable 90-day functional outcome, where we included 3 studies, and less favorable 90-day functional outcome was defined as the modified ranking score of 2 or higher scores. And the modified ranking score is the score to measure the level of dependency on everyday tasks for the patients who experience a stroke. So the odds of having a less favorable 90-day functional outcome were 2 times higher in the group of patients with flare-positive lesions. And our findings were mathematically significant, but also clinically relevant. We also pooled the sensitivity and specificity of flare-positive and flare-negative lesions for the hemorrhagic transformation. While we didn't find a very good sensitivity of the flare status of the lesions, the flare, our analysis show a high specificity, which indicates that patients who also have a flare lesion are more likely to have a hemorrhagic transformation. The same situation is also for the second outcome, where we had a higher specificity for the less favorable 90-day functional outcome. We also pooled the positive predictive values and negative predictive values for both outcomes, and we have a 39% of positive predictive value for hemorrhagic transformation and 83% negative predictive value for hemorrhagic transformation. And here you can also see the positive predictive value and negative predictive value for less favorable 90-day functional outcome. So in conclusion, flare positivity is associated with hemorrhagic transformation and less favorable functional outcome in stroke patients who undergo IVT within the standard time window. Our implication for practice would be that to incorporate the flare into risk assessment and clinical decision making, to use it in the prediction of whether there will be an improvement after the stroke treatment, and in the post-thrombolysis management, like when to start the anticoagulation or antithrombotic treatment after the IVT. But nevertheless, we do not recommend, this should not motivate the physicians to not complete an IVT in otherwise eligible patients. Our implication for research is that we need further prospective studies. We need adjusted analysis to know whether a flare acts as an independent factor. We need external validation in bigger sample, and stratification based on of a sample based on the stroke severity. We have submitted our manuscript previously. It was rejected, and we have just submitted it to the Stroke and Vascular Neurology Journal. My second project is comparing combined intravenous thrombolysis and endovascular thrombectomy and direct endovascular thrombectomy in acute basilar artery strokes. Posterior circulation strokes are associated with severe neurological impairments and potential risk of fatality. Those that stem from the basilar artery occlusion exhibit morbidity and mortality rates higher than 80%. And since IVT is not sufficient to have reperfusion rates, endovascular thrombectomy is the main treatment. However, recent studies, especially those in the anterior circulation, has shown that bridging IVT before EVT results in higher reperfusion rate and better clinical outcomes. So our aim is to compare these two treatments among acute basilar artery stroke patients. Our clinical question is, does combined IVT and EVT result in better clinical outcomes than direct EVT among acute basilar artery stroke patients? Our population is acute basilar artery stroke patient. We will compare the combined treatment and the direct EVT, and our main outcome is 90-day functional independence, which is an MRS score of 0 to 2 and represents complete recovery or good functional outcome. Our second outcome is 90-day independent ambulation, successful recanalization, symptomatic intracranial hemorrhage, any type of intracranial hemorrhage, and 90-day mortality. Our hypothesis is that combined treatment is superior to direct EVT in the treatment of basilar artery stroke. Here is our systematic search conducted in 5 databases. We ended up with around 6,000 studies, and 58 of them were involved in our analysis. Our first outcome is functional independence at 90 days. As I said, is the complete recovery after the treatment. Our study showed that the odds of having functional independence at 90 days were 1.46 compared to the direct EVT, and our findings are mathematically significant and clinically relevant. Our second outcome was independent ambulation at 90 days, which is an MRS score of 0 to 3, so it means the independent walking of the patient. The odds of having an independent ambulation were 1.27 for the patients with combined therapy compared to direct EVT, and our findings were mathematically significant and also clinically relevant. Our third outcome is successful recanalization rate, which is measured by the scale of Tiki, and a Tiki score of 2B or 3 is considered successful recanalization rate, and we did not find a significant difference between the two treatment groups. The same is also for symptomatic intracranial hemorrhage, where we did not find statistically significant difference between the two treatments. And the same is also for any intracranial hemorrhage, where we did not find any difference between treatments. However, in the last outcome, in mortality at 90 days, the mortality rate was, the odds of having of the patients dying 90 days after they selected treatment was lower in the combined treatment group compared to EVT, and our findings are statistically significant and clinically relevant. So in conclusion, we found that from our analysis, we found that bridging therapy provides better functional outcome, independent ambulation, and lower mortality rates without increasing the risk of hemorrhagic transformation, but also not providing a significant difference in successful recanalization rates. We also conducted a subgroup analysis based on occlusion site. So we had studies who only had basilar artery occlusion, but we also had studies who had vertebral basilar artery occlusion. Study site, where the study were conducted in Asia, Europe, and North America, treatment window for EVT, and stroke severity based on baseline NIHSS score. And we found a clearly benefit of combined therapy compared to EVT in all the subgroups, except in the one with about the stroke severity, where we found a significant difference only in the moderate strokes. So in conclusion, bridging IVT or combining IVT to EVT for patients with basilar artery occlusion leads to a higher rate of functional independence and lower mortality rate without increasing the rate of intracranial hemorrhage compared to direct EVT. Our implication for research is that future studies and randomized control trial to have stratified randomization based on critical factors such as stroke severity or time from symptom onset, to have adaptive trail which would lead to involvement of patients who would benefit for treatment, and a longer follow-up than the 90 days that we had in our outcomes. So far, we have completed the article together with a supervisor and scientific advisor, and soon it will be sent for internal review, and we plan to submit it to JAMA Neurology. In summary, these are my projects that I plan to complete this year, and I want to conclude the presentation with this quote: "We learn neurology stroke by stroke." Thank you.
Thank you for your presentation. My question, what was the reason to make subgroup analysis depending on area like Europe, Asia?
Okay. So yeah, we did a subgroup analysis based on study site in Asia and Europe and North America. We did this kind of subgroup analysis because there are the existing RCTs for comparing these two treatments we have existing RCTs only in the anterior circulation, and so far the studies conducted in Asia or more specifically in China, they have shown a non-inferiority of EVT compared to this combined treatment, whereas the studies conducted in Europe or North America did not manage to show superiority or non-inferiority of EVT compared to the combined treatment, and we wanted to analyze whether we have the same pattern in our studies in the posterior circulation.
Why did you choose the flare positivity? There are several other MRI biomarkers as predictive markers for the worse outcome after IVT. Why even flare positivity?
Because I think the other markers are well studied. There were existing studies, longer perspective cohorts on that, but however, flare, there is a small number of studies existed, and they are actually not very recent. So there was a time when flare was more used in the clinical practice, and the idea overall, I think, is to use flare only in the context of wake-up strokes or unknown onset strokes. However, we rarely use it, and we just wanted to show that we can maybe be used also in known onset strokes and can be used in the prediction of the outcome.